1 past the hour. I think we can get started. I have some. I'll ask everyone to mute if you're not a speaker. I'm Tony Latai. For those of you who don't know me, president of the Society for Functional Precision Medicine. It's my pleasure to welcome you to what is going to be another stellar monthly seminar series featuring Diana Azzam and Kurzrock. Before we start, I have just a few announcements I'd like to make. One is, for all of you who are SFPM members and haven't done this already, today, put it on your to-do list, go to sfpm.io and register as a member. We need to update. We've just revamped our membership system. This is a bunch of academics sitting around. We have been doing our best, but we now have a better system than we did before. Please go there and register. It's the way we're going to use to contact you, the way to keep us together as a society. This will also be part of your registration, and membership will be required. As I mentioned, we have some upcoming elections. It'll be in order for you to nominate and vote in these elections, you will need to be registered on this system. As I mentioned before, if you're interested in running for a board position, you'll have an opportunity to nominate yourself. But if you feel like it, you could let me know now to make sure that you don't get lost in the shuffle. Just drop me an email and we can sort that out. I want to bring to your attention that one of our partners, the EHA, the Special Working Group on Functional Precision Hematology, is having a meeting March 25 to March 26, and there you will see a lot of your functional precision medicine brethren. It will be European time, but I am getting up at the brutally early hour required, and some of you might want to as well. Registration is free, and DT has helpfully added a link and a little ad on the front page of the sfpm.io website. You can show up there and kill 2 birds with 1 stone. Usually we have this meeting on the 2nd Wednesday of every month because of ACR. A reminder, next month it's going to be on April 7th, which is the 1st Wednesday of the month. That'll be a one-time deal because of the AACR meeting that follows. Finally, let's make the most of our social media accounts. Please follow us on Twitter. Look at it's the SFPM, and you can find us also on LinkedIn. It's a great way to keep us together as an organization and to increase our voice. So, without further ado, I'd like to introduce Diana Azzam, who I'm very pleased to welcome here. I know she was a very early and enthusiastic joiner of the SFPM, and it's great to see her give a talk. She got her PhD from the University of Miami, and she's currently at the Department of Environmental Health Sciences at Florida International University. And recently I saw her on Twitter. She recently got a grant to collaborate with the Cleveland Clinic on personalized cancer treatment and personalized functional precision medicine. She's in the past focused a lot, I think, on breast and ovarian cancers, but that surely does not seem to be the topic of her talk today. So it's interesting to see that she's branched out, and she is definitely a relatively long-term practitioner of functional precision medicine. So take it away, Diana.
Good morning. Thank you. Thank you so much. It's a pleasure to be here. Thank you, Tony, for the invitation to participate in this wonderful monthly seminar series. So the title of my talk today is Clinical Utility of Functional Precision Medicine in the Management of Relapsed Refractory Childhood Cancers. I'm going to start by highlighting one of the latest trials that evaluated the use of genomics or evaluated the clinical benefit of using genomic analyses to improve clinical outcome in hard-to-treat advanced cancers. And as you can see here, this is a large number of patients, 1,035 adult patients. What they found was that 411 patients had no actionable mutations. And they were able to treat only 199 patients based or match, or they treated those patients with a targeted drug that matched to a genomic alteration. And so out of the 199, they observed objective responses in only 22 of those patients. And so the percentage is 11. I'm sure, I mean, this is quite interesting. The results of this study is interesting and encouraging, and I know that we're going to hear, you know, there are other impact trials that have looked into the benefit of genomics in matching patients, and obviously patients that were treated with matched genomic alterations did better than patients that were treated with non-matched genomic alterations. And I'm sure we're going to hear that from our next speaker. But I want to point out here that only 7% of those patients or successfully screened patients benefited from this approach. And this is really even more challenging when we talk about childhood cancers, because as you all know, pediatric cancers have lower frequency of genetic mutations than adult cancers. And there are very few known driver mutations in pediatric cancers. And hence there are fewer options for targeted therapies. So, there's the study that just came out last month, actually in February, that really confirms what I was just saying, is that, in a total of 153 relapsed refractory leukemia patients, they were able to identify 116 actionable mutations. However, they were only able to treat 17 with targeted therapies matched to a genomic alteration. And their clinical responses were variable. So this brings me to the point that we are in need of more prospective clinical trials. And the other point that I want to say here is that using genomics only may not be the optimum approach. So, basically, this is why we're all here, right? As a Society of Functional Precision Medicine, with the goal of integrating drug sensitivity testing with genomic profile in order for us to improve patient outcome. And I don't want to preach to the choir, as you all know and have seen and are familiar with the scheme that was adapted from Dr. Christer Wennerberg and his colleagues back in Finland, where they have shown that, or where they have developed this platform called functional precision medicine. And really, they have adopted, or basically this is their platform tests directly FDA-approved drugs on primary ex vivo leukemia blasts, and then they identify novel therapeutic, or they identify effective drugs for each and every individualized patient. So my interest in this platform started when I was a postdoc back in 2015, and I wanted to adopt, I started this work and I wanted to implement this approach also in leukemia adult patients and refractory leukemia patients. And as you can see here, this is just a scheme showing a case report of a highly chemoresistant leukemia patient where we acquired sample bone marrow aspirate, we did drug sensitivity testing, and we tested 210 drugs. And out of the 23 drugs that were most potent, as you can see here in blue, the oncologist picked bortezomib, which is approved for multiple myeloma, but not approved in leukemia. And so when the patient was treated with bortezomib, the leukemic blasts went down from 90% to 20%. So this was one of the first proof of principle studies that showed that whatever drugs worked in the lab actually worked on the patient. And so I spearheaded this project, and there's a small cohort of patients where we showed significantly higher response rates in patients that were treated based on drug testing compared to physician choice. But what really struck me then is that, we had 2 AML patients with a similar actionable mutation, FLT3 ITD mutations, but have completely different drug sensitivity profiles. So, this basically struck me to a point where when I transitioned to becoming faculty at Florida International University, my main goal was to adopt drug sensitivity testing along with genomic profiling in advanced cancers. And so the first study that I initiated, going back to, so before that, as I mentioned earlier, childhood, I realized that, childhood cancer is a unique, it's a unique opportunity to implement functional drug testing, just like I mentioned, because they have very few actionable mutations and very few targeted therapies available. So the first study that I got funded and started was a feasibility trial on recurrent and refractory childhood cancers, all types of cancers, where we would implement drug sensitivity testing and genomic profiling in collaboration with Nicholas Children's Hospital. So this study was funded by the state of Florida, first ever Live Like Bella Pediatric Cancer Initiative. And we started the study 2 years ago. So as you can see here in the workflow, samples are acquired during surgery, and then they are sent and processed in my lab. They will be processed, dissociated into single cells, and then we test 103 drugs. I will talk about the library of drugs that we test on those on the patient tumor cells. Then we develop drug sensitivity scores from those response data. We also send out the tumor for molecular profiling. And then I've also assembled a molecular tumor board that encompasses the oncologist, the pathologist, the pharmacist, scientists, and we all come together and look at both the results from molecular tumor analysis and drug sensitivity scores, and then that they would recommend treatment. In terms of the drug library, this is a customized drug library, and the way we, it comprises of 40 formulary drugs that are frequently used at Nicholas Children's Hospital Pharmacy. There are 47 non-formulary drugs, FDA-approved drugs that are known to be in phase 3 and phase 4 clinical trials. So it was a total of 103 drugs that can be, if we find them to be effective, can be repurposed immediately in the clinic. The mutation profiling was basically, we're using the UCSF 500 cancer gene panel. It comprises 529 cancer genes. It's a capture-based next generation sequencing platform. And it looks into, there's 47 genes, as well as large insertions and deletions and structural variants or gene arrangements can also be detected by this assay. So far, the total number of patients is 14, and we actually have processed only 12 patients. So I know that this patient number is relatively small, and we're still recruiting patients until 2022. However, as you see, we've had a large range of different tumor types from these patients, and we've at least processed 7 different tumor types, including rhabdomyosarcoma, osteosarcoma, glioblastoma, Ewing sarcoma, lung tumor, rhabdoid tumor of the liver, leukemias, and ironically today we're actually getting a Wilms tumor. So this is another type of tumor that we haven't, that we will be processing today from a child undergoing surgery. So, I want to say here that I don't want to cluster these patients because functional precision medicine is an individualized approach to treat patients. And what I want to do today is discuss several of those cases and show you, all the lessons that we've learned along the way for each and every patient as an individual. I'm going to start off by showing you a case, a metastatic spindle cell sclerosing rhabdomyosarcoma patient. This is a 7-year-old girl that had gone through at least 3 regimens, processed her tumor, and as you see here, immunohistochemical staining of the original tumor showed that myogenin and desmin were expressed, which are typical of rhabdomyosarcoma. And then we also processed the tumors. We also looked at the expression of these 2 markers on the tumor cells in the lab, on the sample that we processed in the lab, and confirmed that they still expressed the 2 markers here. And so the first attempt we did was we tested 103 drugs, and we found 22 of those drugs that are effective. Now, many of the drugs that have been previously treated, many of the drugs that were previously treated on the patient were ineffective, except for the 2 ones here, the vincristine and irinotecan, surprisingly still had sustained activity on the patient's tumor. So when we discussed this with the molecular tumor board, her treating oncologist, knowing that, wanted us to test the combination that she's familiar with in treating childhood rhabdomyosarcoma, which is a combination of vincristine, irinotecan, and temozolomide. And when we did the combination or the secondary combination testing, we found that vincristine as a single agent was more effective than you add vincristine along with the other two. So based on that, the treatment regimen of the patient was modified. So let me show, what I'm showing you here are, timeline of the patient's response and scans. As you see, in January 2019, the patient had metastatic relapse, and the physician choice here was given, and the patient didn't do very well. I mean, progression-free survival was 2 weeks. And by April 2019, you can see that the tumor progressed. And that's when the patient was enrolled in our functional precision study. We performed molecular tumor analysis, which took 3 weeks, by the way. So we weren't able to use those quickly, since this patient, we needed to take decisions here in a clinically actionable time frame. And so the molecular tumor board recommended treatment based on the drug testing. But even though when we went back and looked at the molecular tumor analyses, we really didn't find anything that was actionable or anything that would be able to recommend treatment, at least in this case here. So when this patient was when this patient was treated with DST guided therapy, in June 2019 we saw a striking decrease in the tumor size. There was the patient actually had an improved quality of life, got out of the hospital, celebrated her birthday. So at least here the patient was doing well for 6 months. Unfortunately, due to metastases in so many other areas like liver and lung, the patient passed away. And this is one of the things that I want to highlight is I wish we had a sample from her metastatic site that probably would have helped us in guiding treatment even better here. So this is an example of a patient that where we really didn't use the genomic profiling that much. However, you can see that the mutations here in the GNAS and NRAS would show maybe genes that are involved in cell cycle or cell proliferation may be involved, and this is why these drugs were effective. Now, in this case here, what I'm going to show you is an example of where the genomics was in concordance with the drug sensitivity testing. So this is a 21-year-old boy with Ewing's sarcoma, and what we found obviously is that he had the typical gene fusion. What was very interesting is that we found a mutation in TOP2A, which is a topoisomerase enzyme. And so this indicated the DNA topoisomerase inhibitors may be effective in this matter. And what was very striking is that when we looked at the drug sensitivity profile and the drug sensitivity results, 29 drugs were effective, and out of the 29, 7 drugs were DNA topoisomerase inhibitors. And so this was one of the examples where we saw, that the genomic results were in concordance with the drug sensitivity results. This is another example where we saw the same thing as well. This is a 4-year-old boy with alveolar rhabdomyosarcoma of the orbit. Here, what we found was that the actionable mutation is a PAX3-FOXO fusion positive, but what we also found was a mutation in SMARCA4, which is a chromatin remodeler. And so this indicated that probably an epigenetic targeting drug may be effective here. And interestingly, when we looked at the list of drugs that were most effective, the top 2 drugs that were most potent were histone deacetylase inhibitors. Sorry. In this case, we had a metastatic beta HCG producing osteosarcoma patient. This is one of those very rare osteosarcomas in which the patient was a 17-year-old with very high levels of beta HCG, blood beta HCG levels. It's a pregnancy hormone, but the patient is not pregnant. So what was very interesting about this tumor in particular is that when we processed the tumor in the lab, and as you can see, when we plated cells at time 0 and went home overnight, we came back and the cells were completely confluent. These cells grew like weeds, very high proliferative rates. And so when we looked at the number of drugs that were effective, we found only 9 out of 103 drugs, as you can see with high DSS scores. And interestingly, 3 out of those were mTOR inhibitors. And so we got excited, and we decided that we would want to test the mTOR inhibitor in combination with doxorubicin or methotrexate, which are standard of care in this type of flare-producing osteosarcomas. And we found that rapamycin with doxorubicin was most effective. So based on that, again, showing you the timeline or the timeline of the patient and the clinical course, in January 2020, the patient had metastatic disease to the lungs, but in a month, February 2020, tumor progressed. There were increase in size of the nodules, and that's when the patient was enrolled in our study. And based on drug-guided therapy, the molecular tumor board recommended the addition of rapamycin and doxorubicin. And in just a few months, the nodules decreased in size and there were no new nodules formed. What was also interesting is that the blood beta HCG levels were reduced. So we found some response on the patient. I also want to show you here the utility of drug sensitivity testing in identifying novel options for really rare tumors. This is a rhabdoid tumor of the liver. It's very rare. You have 20 to 25 new cases a year. And what we found that we had at least 35 drugs, not at least, sorry, there were 35 drugs out of 103 that were effective. So not only what I'm showing you here is that, yes, drug sensitivity testing can provide novel options, right, for the patient. But what was really interesting is that we wanted to test the drug that was recommended by a Foundation One report, which is because what they found was a smart CB1 loss in this particular tumor, and the therapy that was recommended was tazemetostat. So we ended up testing that on the patient's tumor and found that the drug was ineffective on this patient. What we also did was there were chemotherapy regimens or roadmaps that are known to be used in treating rhabdoid tumors. So we went ahead and wanted to test 2 different combinations. And what we found was the combination on the top was more effective than the combination on the bottom. And so the molecular tumor board ended up recommending this combination instead of this one. So the whole point here is that drug sensitivity testing not only can be used to identify novel options for the patient, but can be also used in guiding treatment, as you can see here. I want to conclude with this case where we found a sweet spot in finding an actionable mutation with a targeted therapy, along with adding drugs in combination from drug sensitivity testing. So this is a perfect case, right? Where we had a metastatic osteosarcoma patient of a 9-year-old girl. She has Li-Fraumeni syndrome, so she had CNS tumor at birth. But what we found, as you can see, first, when we dissociated the tumor, I want to point out that the morphology of the cells are completely different. So when we look at the morphology of these cells, from 3 different osteosarcoma patients, we found completely different morphologies. But what was really beautiful about this is that the molecular tumor analysis showed an NTRK3 fusion, and this fusion has actually a matched. FDA has approved a matched larotrectinib as a matched drug for this fusion, and so this was suggested based on the fusion that we found, and then the drug sensitivity testing showed idarubicin to be the most effective here. So this was also picked by the molecular tumor board. And what was also interesting is this montelukast, which is it's an anti-allergic medication that they ended up picking. So the combination of those 3 using genomics and drug sensitivity testing was recommended by the molecular tumor board. And this again showing you the response timeline. So in June 2019, this patient had metastatic disease to the lung. August 2019, there was tumor progression. There was physician choice, third regimen. Still, she had tumor progression. And after guided therapy, till now, this patient remains cancer-free. So it's been 1 year already. All right, so our prospective feasibility study so far has demonstrated that ex vivo drug sensitivity testing can be performed within a clinically actionable time frame. The median is 7 days. These data informed recommendations by the Molecular Tumor Board for personalized treatment. DSS, in some cases, synergizes with genomic data to further refine treatment recommendations. So we've recruited 14. Today we'll have 15. Out of those, 10 received MTB guided therapy. Sorry, this was a mistake. And 8 out of 10 have improved clinical outcomes so far compared to their most recent regimen. Clinical evaluations of their progression-free survival and overall survival of patients is still pending. And we're currently recruiting additional patients. So even with a small number of patients, our study justifies continued development of this functional approach to personalized therapeutics in advanced and hopefully in newly diagnosed cancers. I have just initiated 2 other feasibility studies, one with Nicklaus Children's Hospital, trying to assess or wanting to assess predictive value of functional precision medicine approach in newly diagnosed childhood sarcomas. And I also just started a new study with Cleveland Clinic on the utility of drug testing and genomic profiling in advanced adult sarcomas. So my long-term goal, along with everyone here, I'm sure, is the launch of large-scale prospective randomized trials to better assess the clinical utility of functional precision medicine approaches. Before I end, I want to thank my lab members, my team, especially Arlette and Ebony, who are active players in this project. I also want to thank my dean, Dr. Tomas Gelarte, and all his members for their support. I also want to thank my collaborators at Nicklaus Children's Hospital, the doctors, the clinical coordinators, the pharmacists. They've been amazing, and without them, this study wouldn't be possible. And at the end, I want to thank the foundations that support my work: Live Like Bella, Cornelia, Scott McKinsey, and State of Florida. Thank you. I'm ready to take any questions.
Great, thanks a lot, Diana. That's very interesting, very challenging set of patients to have to go through because all the tumors are likely to be so different.
Yes.
You have a set of questions. I'll try to, I think I'll start with one that kind of combines a question from Larry Boyes and me, and that is, you identify a lot of non-formulary drugs and sort of non-FDA approved drugs singly, giving you the problems of reimbursement and pharmacy approval, number one. Then you have the issue that you seem to identify and actually give in some cases novel combinations that have never been combined before, bearing with them the risk of sort of unknown toxicities. How do you dose them in those novel cases? So basically, how do you get it approved and paid for, and how do you figure out dosing in these complicated combos?
So this is all the work of the doctors, right, and the pharmacists. So this is why what we do, this is a learning process, and we've learned a lot in the past 2 years. First, to get it approved, this is why, in many situations, unfortunately, oncologists don't end up using the most effective drug. So they end up, I don't know if you saw, but they end up sometimes picking drugs that not are the top, but maybe in the middle, because of the fact that they could be reimbursed reimbursed and approved by insurance companies. So that's number one. Number two, we always compare the IC50 of each of these drugs to the pharmacokinetic data of the drugs. So the Cmax of the drugs and the blood on the patients. So we always go back to the pharmacokinetic data that's already out there on each and every drug, because all these drugs are FDA approved.
Okay, somewhat related to that, you're often in a situation where you have a list of drugs, more than you're going to give the patient.
Yeah.
how do you go from a list of, say, I don't know, 20, and then eventually give the patient just 1 or 2 of those drugs? How does that decision get made? What's the thinking inside your board?
So I think they put them in tier 1 and 2 and 3, and again, I mean, they obviously the best case scenario would be to sequentially get samples, right? So I'm very hesitant to get a sample from a patient, and then they go through treatment. Let's say the patient relapses, and then they go back to the drug testing results and want to go back and try to get to use those results again. So I try to inform them that the tumor changes, and we really need to get another sample so we can test the tumor again, so I can better, so we can better inform treatment decisions. I've had challenges where patients need radiation, and and then some of the oncologists will be, okay, we'll give radiation, and maybe we'll try to look for the drugs in the drug testing results that you show us. And I tell them that's impossible, because radiation will change the tumor. So we've had those challenges where we really need the timing of the sample and when to get the sample for drug testing is important.
Okay, it surely is. One last question, then I think we'll have to move on. How long are you culturing the cells for before you start the drug testing, and how long after you do the drug testing?
So I mean, as you saw, the median time from when we get the sample until we get the results is 7 days. So depending on the sample, depending on the size of the sample, I don't go more than 5 to 7 days, or more than 10 days, depending on the type of tumor.
Okay, thank you. I think we'll.
Could I make a comment?
Oh yeah, sure.
So what you've done is phenomenal, and I really love it. And we'll get into a little bit more about the novel and the functional and being able to implement this. The only little thing I want to make a comment is it doesn't seem like there's been much of an emphasis on immunotherapy. Yes. And 2 of your children, the 9-month-old and the 4-year-old, have SMARC alterations. And those alterations have recently been shown to be enormously sensitizing to checkpoint blockade. So if those children have relapsed and are still alive, I'll just say that it may be worthwhile to try checkpoint blockade on them.
Absolutely. That's a very good point. And that's the other limitation of using ex vivo testing is, at least till now, we're unable to test immunological immunotherapies. Hopefully with time, as a team here, we'll be able to optimize this assay even further to test those type of immunological drugs.
Right, but the SMARC, I just wanted to mention that is there's a lot of emerging data about that, and we've seen it ourselves. So
all right, it's good to know. But Foundation didn't really mention any of those.
It doesn't matter what Foundation mentions.
Okay, good. We agree.
You can look it up in the literature.
We agree then. Thank you.
I'll just point out, available to members is a very recent talk at this series by David Barbie. And David Barbie actually has investigated ex vivo testing of cancer cells to evaluate their sensitivity to checkpoint blockade inhibition. Nice. So we'll just leave that there if anyone wants to look into that. So moving along, it's my pleasure to introduce Dr. Rizal Kurzrock, who's the Murray Professor of Medicine at UCSD and the Associate Director of Clinical Sciences at Moores Cancer Center. She has long been a proponent of personalized cancer therapy. And I would say, from my perspective at least, what discriminates Rizal from some of the other people working in the precision medicine field is her apparent desire to actually empirically test the efficacy of different precision medicine approaches, which I think all of us can learn about, because it's absolutely essential for moving forward, whatever the specific diagnostic technique you're using. It's a new world to actually design and run clinical trials, not to evaluate a specific therapeutic, but rather to evaluate a diagnostic strategy. I think that's something that Rizal's done some ministry work on. So I'll stop now and let her describe her work.
Well, first of all, thank you for the invitation. And I just want to make sure everybody can see my screen. Yes? The screen is visible?
There is like a white triangle on mine.
I can't get rid of that.
Okay.
So you're gonna, unfortunately, you're gonna have to live, but if you can see the screen, that's great. Okay, so what I wanted to say is what I'm gonna talk to you about is the use of genomics and other omics. And where my talk, in contrast to this previous speaker, we haven't done that much functional, which I love what is being done. But what we have done a lot of is figuring out how to implement the system. And what when you look at some of the papers in the literature, and I'll contrast it to what we've done, they get stuck on the implementation. They get stuck on getting the drugs. They get stuck on doing the drug combinations. And we have figured out how to do that. So we get almost any drug we want over 90% of the time. Furthermore, I think the other problem with many of the studies where the response rates are low is, first of all, we think 90% plus, maybe 95% of patients have actionable alterations, but they don't have one actionable alteration. They have multiple actionable alterations. And it's really naive to think that you're going to have a big impact on a complicated tumor with one drug. I mean, sometimes we hit it lucky with like the NTRK inhibitors, but what we've done is we've done customized combinations of drugs, and we've done lots of novel combinations, probably a couple of thousand patients. We figured out how to dose it all safely. So that's what I'm going to talk about, is how we do N of 1 of combination therapies. But I want to emphasize right at the beginning that an essential part of this that I think is not thought enough about is the implementation. You can have the best assays, but if you can't get the drugs for the patients, that study doesn't run. And I think that's what's really hampered a lot of precision medicine, mainly because it's a new way of doing things. Why won't this move? Okay. Good. These are my disclosures. And just background, I'm at UCSD. I run the Center for Personalized Cancer Therapy. Before I was at UCSD, I was the founder and chair of an early phase clinical trials department at MD Anderson, which really grew to be probably the largest of its type, maybe in the world. And it was there that we began to get a glimpse, circa about 2007, what the power of genomics was. So the take-home points, this is all about getting the right drug and really the right drugs to the right patient at the right time. First of all, at the genomic level, every metastatic tumor is unique and complex. I live in California, I lived in Houston, but I'm from Canada. I think of metastatic tumors like malignant snowflakes. They're each different and they're each complicated. And that means that the old traditional way of doing things doesn't really fit. So that means that metastatic disease requires customized individual combination treatments, not single agents. The pillars of precision medicine are genomics and immunotherapy, and they are married to each other. They are not separate. And immunotherapy is best suited for genomically complex tumors. So all of this has been driven by breathtaking evolution in technology. I'm old enough to remember in the 1990s when everybody said the human genome could never be sequenced, too complicated. And of course, it was sequenced in the early 2000s, took 13 years. Today takes a day. The cost of sequencing was initially $2.7 billion. I know everybody complains it's expensive, but it's gone down precipitously. And we can get sequencing now for $1,000 to $5,000 per patient. So really, the technology is breathtaking progress, in my mind, unparalleled in human history. But this also means that it's revealing things to us about our standard ways of doing things, that the science is speaking to us and saying, well, the standard way of doing things doesn't really cut it anymore. And that's been some of the difficulty. So we're beginning to evolve our clinical trial design. Initially, lung cancer was one disease. And then we figured out that lung cancer was many diseases, you know, the EGFR subtype and the BRAF subtype. And then we went on to figure out that we could have the same genomic alteration in multiple different tumors, and we could do tumor agnostic studies and even get tumor agnostic approvals, an idea that was absolutely outlandish in 2007 when we started the program at MD Anderson, but now is now FDA approved. And this led from these large randomized trials of unselected patients to a new model of very small trials with highly selected patients, where we expect many, if not most, patients to respond and even lead to FDA approvals. And so coming out of this really rapidly, a new era was born. And the first part of that new era was tissue agnostic approvals driven by genomics. And the first one, and this is really important, is the FDA approval of pembrolizumab for solid tumors based on mismatch repair gene defect, May 23rd, 2017, really, I think, transformed the scene for three reasons. The third reason being probably the most important, but the least acknowledged. First of all, it was the first tissue agnostic approval for all solid tumors. Second, it was an approval for an immunotherapy based on a genomic marker. And then the third reason, which I think people are least aware of, it was an approval for the first time based partly on retrospective real world data. And now we have other approvals that are completely on real world data. So a whole new, I mean, using our powerful computerized records, which we didn't even have 20 years ago, is now a potential basis for approval. And then, of course, that's not the end of it. Larotrectinib for NTRK fusion adult patients, entrectinib for NTRK fusions, and pembrolizumab for high tumor mutational burden, just approved a few months ago. And I think there's going to be many, many more like this. And what is marked about these approvals is some of the really high response rates. With entrectinib and larotrectinib, the response rates are usually 55 to 75% with single agents, which is pretty amazing. But again, most patients are not cured, and most agents don't do as well as this. So let me move on. And I mentioned that one of the important things was that genomics and immunotherapy and how they come together. And so these are the pillars of precision medicine: genomics, immunotherapy. And I want to emphasize that people think of them separate, but we think of them as a couple, and they're married to each other. And this is now apparent from many ways. So genomic aberrations predict response to immunotherapy, PD-L1 amplification, high TMB, DNA repair gene alterations. And I mentioned the chromatin remodeling genes like SMARC now predict response to immunotherapy. And amazingly, the more mutated the tumor, these tumors that we used to hang our head and think, oh, this is such a messed up cancer. But now the more mutated the tumor, the better the response to immunotherapy. And some of the very high mutational burden tumors are where we see really incredible responses with complete remissions. And this makes sense because once we use a checkpoint blockade to reawaken the immune system still has to recognize the tumor. And by having a lot of mutations, the tumor is very different than the normal cell, and much better chance that a reawakened immune system will actually recognize that tumor and then eradicate it. So we formed a rare tumor clinic, which was a precision medicine clinic. We concentrated on rare tumors because they're about 25% of the cancer burden, individually rare, but they were a great way, real big unmet need. And what we do there is, we make a diagnosis like everybody else does under the light microscope, but we have a master protocol that covers the entire institution. And every patient gets a bevy of comprehensive molecular profiling, tissue sequencing, immune sequencing, liquid biopsy, and so forth. And this was initiated when I came to UCSD around December 2012. And we've probably done molecular profiling, clinical grade of some type on about 21,000 patients. And then we have a molecular tumor board where we discuss these patients, and we bring in our scientists and our computer experts and all our different physician experts. But the idea is actually to give therapy. And so we're very interested in research, but our specific aim is to treat these patients. We just published 715 patients in Nature Communications. We ended up treating, I think, 429 of them. So much higher treatment rates than in other studies. And then I'm going to just give you a couple of examples. This is a patient, I actually saw him in clinic last Friday, so it'll give you a hint that he did well. He had metastatic basal cell carcinoma. He was a 55-year-old man. He saw me in October 2015, so 5.5 years ago. He was treated with 6 prior therapies. He was treated with the classic FDA targeted therapies that are approved for patch 1 alterations, vismodegib and sunitinib. He failed everything. He was in a wheelchair, really pretty bad shape, had liver, bones, and brain metastases. And what would you do next for the patient? Well, probably the right answer was sent to hospice, but we ended up doing comprehensive genomic profiling and enrolling him on our master clinical trial. And this is what we found. The first thing is, if you look at his genomic profile, this is Foundation Medicine, you can now understand why he didn't respond to the molecules like sunitinib and vismodegib, which target patch 1. He had multiple other co-alterations. He ended up, we now know, we didn't know at the time, but we now know he had a high tumor mutational burden, and he had PD-L1 amplification, which predicts response to immunotherapy. So we gave him immunotherapy with nivolumab. This is his liver tumor before, this is his liver tumor after. As I said, I saw him in clinic last Friday, and he has a complete response that is now ongoing at 5.5 years. So this illustrates how you can use genomics to match patients specifically to therapy. But I want to also say that you can use genomics to say which patients shouldn't get therapy. So we all love immunotherapy because of some of these great responders, but I want to say it's not all good. We've seen hyperprogressors. Hyperprogressors is when there is accelerated progression on immunotherapy. It's like pouring gasoline on a fire. This is an example of a patient that we published, breast cancer 2 months before immunotherapy, right before immunotherapy, not much of a difference. She gets nivolumab and she explodes in 6 weeks. And that's what hyperprogression is. And she had an MDM2 amplification. And so what we know is that the 2 alterations that can predict for hyperprogression are a subset of patients with EGFR alterations and MDM2 amplification. That doesn't mean that every patient with these alterations will hyperprogress, or that every hyperprogressor will have these alterations, but it means that these patients are at real risk for hyperprogression. And so therefore, important point, next generation sequencing can help define not only who to treat, but who not to treat. Here's another patient from our rare tumor clinic, a patient that I saw in January 2016, 49-year-old woman from Saudi Arabia. And she had flown here, and this is going to illustrate new technologies and how we can exploit them. She'd had surgery, radiation therapy, chemotherapy, and she actually came too late. She was sort of like in trouble. She had a huge abdominal tumor. She looked like she was 8 months pregnant, but it was all cancer. She had an impending bowel obstruction, impending kidney failure because of his obstruction. And then, the question is, what is the right thing to do next? Again, probably hospice was the right thing, but we decided, especially because she came from far away, that we would do comprehensive genomic profiling and enroll her on our master protocol. But we had a big problem. She didn't have much time to live. She had 7 or 10 days or at most to live with all these kidney and bowel obstructions. So we didn't have time to get her tissue biopsied. So we did a liquid biopsy, blood-based genomics. We've done almost 6,000 patients. And remember, this is January 2016. This is what we found in her blood. Most patients have 3 or 4 alterations, and she had about 20. So we just guessed that this might be hypermutated. And we ended up treating her with nivolumab, and this was her tumor before therapy. This is 8 months later. My last contact with her was after 3.5 years when she went back to Saudi Arabia, still in complete remission. And then we did the tissue at the same time, and the tissue confirmed what we saw in the blood. She had multiple alterations. This is Foundation Medicine again. Usually you have about 4 alterations. She had, I think, 23 here. She had a high mutational burden. It turned out she was microsatellite unstable with an MSH2 alteration. But I think this illustrates how we can just use new technology like blood to get quick answers. So that's the important point here. The use of cutting edge technologies, which were almost unimaginable a decade ago. And now blood-based tumor mutational burden and microsatellite stability is available on a routine basis from blood-based tests. But what if every patient with metastatic disease is different? Malignant snowflakes, as I mentioned to you before. And that's really what we think is true for patients. And just here is an example. I told you we've done thousands of patients, but here's an example of a few breast patients that fit on the slide. And you have 2 patients with ERBB2 amplification. So the way we classically do things, these patients get an ERBB2 inhibitor, HER2 inhibitor. And of course that makes sense, but it's not their only alteration. And it would just make sense that we need to be able to hit some of the co-alterations. First, that's first. And then second, it doesn't make sense that they go on the same regimen. They have HER2 in common, but the rest of their portfolio is different from each other. So what we decided to do is instead of using a consistent drug between patients, even in the presence of different molecular profiles, we'd use a consistent strategy and allow different drugs. And what that means is that each patient gets their own customized regimen, even if they have commonalities. Unless they're identical, which is really rare, they get a customized regimen. And so we created the prospective trial called iPredict, which is investigation of profile-related evidence determining individualized cancer therapy, where we gave customized combinations. We also have a part of it where we give newly diagnosed patients with lethal malignancies. We've treated about 51% of the patients that have enrolled. And the paper was was published now. It's Nature Medicine 2019. And that's the first rendition of the paper. We have others that we've submitted, but here is a glimpse. So the first thing that we learned is matching patients to therapy isn't a yes or no answer. It's about the degree of matching. And if you have 10 alterations and you match only one of them, that's not a high degree of matching. We consider it when we score it 10%, 1 out of 10. So what we looked at is high matching versus low matching, more than 50% matching versus greater than or less than 50%. And the response rates are vastly different, 45% versus 16%. Progression-free survival is vastly different too, but what I'm going to show you is the difference in overall survival. High matching, over 60% at 2 years, low matching, about 20% at 2 years. So our conclusion was that the better match the patient, the better the response rate, the better the progression-free survival, and the better the overall survival. And that just thinking about matching patients as a yes or no was not an adequate answer for patients with complicated tumors that have multiple alterations. So I'm going to give you this patient just as an example of a patient was presented at Molecular Tumor Board. The patient has a KRAS alteration. It's an unusual alteration, but it is pathogenic. And we chose a MEK inhibitor, trametinib, for the patient. And I know you've heard rumor that that doesn't work, but we recently published a paper that shows that it does work. Only it doesn't work in isolation because you have to target the co-alterations. So the other alteration the patient had was ARID1A, and this is a chromatin remodeling gene. It can sensitize to immunotherapy, but it also can sensitize to PARP inhibitors. So the patient got olaparib as well. You can see the response. It's a beautiful response that is ongoing now at 15 months. I just want to mention some other things that I'm involved in that I think are also important. So Worldwide Innovative Network for Personalized Cancer Therapy, Mission Global Delivery of Precision Medicine. And here we want to emphasize going beyond genomics. We've done a lot in genomics, but we need to go beyond it. Transcriptomics, proteomics, epigenetics, and of course, what you're doing, functional genomics, may be the most important thing of all. And Wynn has emphasized really the transcriptomic part. And we ran the first solid tumor precision medicine trial using both genomics and transcriptomics, again, published in Nature Medicine in April 2019. And we were able to show that transcriptomics significantly adds to the number of patients that can be matched and to the robustness of the match as well. And then I just want to mention one last trial that is just launching, and that is a master observational trial. We published the ideation for this in Cell in 2 papers last year, and it's called the Root trial, and it's a master registry of oncology outcomes associated with testing and treatment. And of course, more and more people are doing this in order to get national level data. Last thing, what about the host? We haven't done a very good job looking at the host. And the host may mediate toxicity, immunity, and so forth. This lady is obviously robust at 100, smoking a pack a day and in your face. And the question is this good luck or genomics? I think it is her genomic portfolio. And then finally, the genomics immunotherapy era will revolutionize not just cancer medicine, but probably all of medicine. This is just a fascinating little thing. FGFR mutations important in diseases like bladder cancer. The identical mutations actually are responsible for achondroplasia. And, the question is, are there implications for that as far as treatment? So I just want to thank our precision medicine team, and I will stop there.
Great. Thank you very, very much, Roselle. It's very interesting and a very, I'd say, it's a great tour of the commitment you've had to precision medicine over the last decade, at least, I guess I would say. I have a question, then we can get into a couple of the other questions. My question is, given what you've said and your obvious ability to embrace new technologies, what do you think about incorporating into your multi-omic strategies a functional strategy? Basically, I mean, for us, it's just so commonsensical. You take the drugs you're interested in, you put them right on the tumor you're interested in, and see what happens.
We'd love to.
So what do you think about incorporating that into some of your flows?
We'd love it.
Okay, great.
Absolutely. I think it's been a weakness of our program. I think our program has been extraordinarily strong, but that has been a weakness. And I think that's a very important next step.
Maybe I'll talk to you a little bit more about that offline then.
Absolutely. Happy to do that.
Okay, great. From the chat, we have a question from Europe, from Sigrid Scanlund of Norway. Very impressive study, thank you. It's nice to see these success stories. I'm wondering, how often are your treatment predictions successful versus not successful? Do you have any sort of summary statistics to, because this is a real challenge, how to generate, you know, a standard way of generating summary statistics for diagnostic strategies?
So to be short, we've actually published some of the preliminary papers, and so we published the I Predict paper in Nature Medicine. The first author is Cyclic, and I'm the last author. And we published a molecular tumor board, which is the same idea. So the I Predict paper had 149 patients, and we treated 83. And we matched 73 patients. And the molecular tumor board paper, which we published in Nature Communications just a few months ago, Dr. Cotto is the first author, I'm the last author, so you can find the papers. We looked at 715 patients, and 429 were treated. So if you look at the overall big picture, as I mentioned, usually about 45 or 50% of patients that are high matches will respond. And then the question is, what is the overall response rate? It's probably about 25%. When you decrease the number, you boil it down to patients that didn't get a high match and so forth. But I will say that the caveat is that a lot of these patients are put on study, and I showed some of them when they're on death's door. It's very late. Doctors wait too long to put them on study. So I think it's actually a pretty impressive response rate. And with time, our doctors learned to do things earlier, to begin to look at the genomics before the patient had progressed, not after they were progressed and had impending kidney failure and bowel obstruction. So that's overall, but I would point you to read the papers, and that will give you a more granular view of what our response rates are.
Thanks. The hour is late. I'll give you one closing question I think impinges on everything in this world, and that is, to summarize, how do you pay for it all? A lot of tests, a lot of novel drugs. How do you get it paid for?
This is, I'm not being sarcastic. We hired a magician, and she is able to get virtually any drug for us. So she's not really a magician. She's a medication acquisition specialist. And there are a lot, at least in the United States, there are a lot of programs to get these drugs. The problem is the doctor in the clinic with 20 patients cannot figure it out. So we hired a person that came from an insurance background, who I call her a magician. She's really devoted and she's really good. And she gets the drugs for us. She's enormously successful. There are actually a lot of programs in the United States where you can get the drugs. And the thing is, you have to have, this is the implementation part, you have to have somebody that will have the time and know what to do. So our doctor in the clinic says what drugs they want, and then they call our, in quotes, magician, and her name is actually Letty, and Letty gets the drugs. And so that is the implementation strategy.
Roselle, that is a fantastic answer. I think everyone on this line, I think implementation is a huge hurdle. And I think one thing I've learned in trying to, on the regulatory side of things, is that many of the people who are on this call with us, they just don't know anything about it. If they're like me, they don't know anything about regulation. And you can cure a lot of these problems by getting the right people who do know it. There's stuff that I don't know that there are people who know, and they can really accelerate your program. That's very helpful. The final summary comment is I think we've learned from both the people who spoke today, the importance of the ultimate goal of precision medicine is not to identify single drugs that will give us cosmetic responses, but to identify the combinations that are really going to change the way people live when they have cancer. And I think we've had nice demonstrations from both speakers on this. So with that, I'll thank you very much for two very interesting talks, and we'll close this month's seminar series. Thank you very much.
And thank you for the opportunity to speak and the opportunity to hear Dr. Azzam's functional.
It was my pleasure too. Thank you.
So Rizal, come join us and get your group to attend our monthly seminars. We'd be very happy to have their perspective to join to ours.
I'd be happy to do that. Just send me some links and happy to do that. This is great. Thanks.
All right.
Hey, Rizal, are you still there? Rizal, can I talk to you for a second?
Sure.
This is Chris, kind of from Seattle. And we invited you to the Forbeck meeting last year down in San Diego. You couldn't make it, but I would like to follow up. I'll send you an email. So it's going to come from me, just so now you can put the email to a face about your ideas about, as Tony said, implementing functional testing in your tumor board. And we can talk about it now, or we can talk about it later. I'll send you an email and we can maybe set up a call or something.
I think setting up a call, I actually have a follow-up call. So
yeah, sure. Got it.
But,
okay.
But just ping me and
yeah, thank you very much, Rizal. It was wonderful, wonderful story. Fantastic.
Okay, thank
Okay.
you.
Bye-bye.
Bye-bye.